Hi, and welcome to Chapter 4. We are going to discuss the positioning of the digits 1 through 5. Same thing that we took into considerations for the wrist and hand, we also need to take into consideration for the thumb and fingers. So you need to set your technique, make sure your room's ready. You're going to use a 40-inch shield, make sure you got your markers, your shielding, and your lead strips if you're going to use those to help prevent fogging. We will concentrate on just a few of the views today. Your AP is just for the first digit, which is your thumb, and the PAs are for the rest of the digits, so second, third, fourth, and fifth digits, or your fingers, index fingers through your pinky. We also do obliques, and we do laterals, and we'll talk about that. If you have an 8x10, you can certainly use that cassette size, but most facilities are going to have 10x12s, and so you'd actually grab the 10x12 cassette. If you're using digital, you'd use the 14x17 and collimate down to the skin margins of the fingers. So let's talk about the first, your second digit, which is your index finger. You will do a PA, oblique, and a lateral for this. Your central ray is directed to your proximal interphalangeal joint. You'll see on this cassette they actually have them centered to the cassette. They've collimated down to the skin margins, and they have a marker at the top distal portion of the finger. Here's your obliques, they're 45 degrees, again centering to your proximal interphalangeal joint. And you can do your obliques depending on the protocol for the hospital. You can rotate them on the sponge so that the digit's furthest away from the film, but this causes a lot of OID. So some facilities prefer that you rotate it medially so that you can help to decrease that. Your lateral finger, again, you want to keep that as close as possible so you can see with the second digit they are actually placing their finger on top of the cassette and rolling it into a lateral position. With the third digit over here, you can see that they are trying to keep it so that it's still in a lateral position, but there's nothing you can do about the OID. You're going to have some OID with that position. Your thumb, that we do these in APs, so you're actually going to have to turn the hand behind your patient so that we can again minimize that OID. OID causes magnification, which causes a loss of recorded detail. So when possible, we want that patient to flip their hand so that that thumb rests flat on the film. If your patient cannot do that, then you can always use a sponge, roll them up, and you're going to have OID. So if this is more comfortable for your patient, you can certainly do it this way, but most facilities are going to prefer if you can actually place them on top of the cassette. So your criteria when we're looking at the thumb and the fingers, your hand's going to be pronated in a PA position, your fingers extended. That central ray is going to fall in the proximal interphalangeal joint. For your thumb, it's the metacarpal phalangeal joint. You're going to include at least the distal portion of the metacarpal. Sponges are available if you need them. You're going to separate those fingers from the affected finger, and lateral and oblique should be the side closest to your film. Your technique, most facilities will use anywhere between 50 and 60 for your KVP. Mass will depend again on the type of equipment you're using, so anywhere between 1.5 to 3.2. Some facilities, I've seen them use 5 mass, so again, it just depends on the unit. Make sure there's no motion. If there's foreign bodies, such as glass, you're going to use a decrease in your mass so that you can decrease the density on the film. Make sure you always check your hospital's technique charts and follow whatever their protocol is. So here's an example of that PA oblique and lateral. Again, patients sitting at the chair. They are going to place their hand pronated onto the table. They are then going to position themselves into whatever you need them to. So if it's an AP thumb, you are going to then turn their hand behind them and supinate it, and you'll center on that MCP joint. If it's a second through fifth digit, just lay their hand pronated and center on that PIP joint. Here's an example of the PA, the oblique, and the lateral for that second digit. You'll see that they actually collimated down. They have the entire finger on the film down to the carpals. So again, 10 by 12s. If you are at a facility with manual films, you're going to want detail cassettes. You do these all tabletop, 50 to 60 kVp. Patient seated at the end of the table, pronate their hands and fingers, separate the fingers, center to the PIP joint for the 2nd through 5th digits, 40-inch SID, collimate down to the skin margins, place the appropriate marker, and you're going to use shielding. When we take a look at the image, you want to see all the phalanges, no rotation, no overlapping of fingers. Make sure the joints are nice and clearly open. Your central ray must be directed to the PIP, and make sure that you have an optimal technique. So you should be able to see that brightness level and dynamic range correctly. When we're looking at obliques, again, the 2nd through the 5th digits, you're going to rotate your patient. You can use the sponge into a 45-degree angle. SID will still stay at 40. If you're using manual techniques and manual film, you're going to use lead blockers to help divide the film into 3s. If you're using digital or CR, you'll just use your 10 by 12 or your 14 by 17 digital plate, and you'll collimate right down to the finger. You can use a sponge if you have it available to help rotate the hand into a 45-degree angle, collimate down to that finger, and place your marker on the film. So again, make sure that you can see those joint spaces, no overlapping of the fingers, pretty much the same criteria as that first PA film. Lateral fingers, you're going to shoot the 2nd digit medial to lateral. Your 3rd and 5th digits will be lateral to medial. All use a 40-inch SID. You can use sponges, make sure your finger remains parallel to the image receptor, and collimate and make sure you have the appropriate marker. So again, here is the lateral film. Joint space is open, central ray to the PIP. Make sure that you can see trabecular patterns and no motion. Your thumb is the exception to this. This is a child's thumb. You can see those epicondyles, so the growth plates have it filled in. You use a 10 by 12 digital plate, 14 by 17 collimate down to the thumb if that's what you have at your facility. Central ray to the metacarpal phalangeal joint. Internally supinate the hand to put the thumb into an AP position and collimate down. If your patient can't do that, then obtain a PA. When you're evaluating your thumb, you should be able to see the central ray through the first MCP. Make sure that you have all the way down to the carpal metacarpal joints. A lot of arthritis occurs down here. You want to make sure that you have that in case the patient's experiencing pain. Otherwise, you're going to have to do additional views. So the oblique thumb, again, different from the 2nd through the 5th digits. You are going to lay your hand down flat on the table. You're going to use a 40-inch marker, a 40-inch SID with a marker, and collimate down. So basically your hand's in a neutral position when you lay it on the film. So again, centered at the first MCP, and you're looking at probably around 55 at 2.5 for most techniques. Your lateral thumb, this time you're going to pronate the hand, but your thumb is going to roll up into a lateral position. Central ray will be at the first MCP. Again, you should see a nice lateral, true lateral of your thumb, centered to the first MCP. Make sure your markers are visible on your film.